Welcome to the deep dive. Today, we're plunging right into this incredible world deep inside us, the amazing universe of our own cells.
hmm
These aren't just, static building blocks. They're more like bustling, tiny cities constantly reacting to their environment.
Yeah, adapting to challenges, or sometimes when things get too much, facing injury.
Exactly. It's this microscopic drama playing out every single second, and it really governs our health.
And today, we're basically going to be your guides through that drama. We'll look at the really ingenious ways cells adapt to everyday stresses, figure out the difference between damage they can bounce back from and, the point of no return.
Right.
And then we'll unpack the different paths cells take when they are injured or even when they perform this kind of programmed self-sacrifice. We've pulled together a whole stack of detailed sources, hoping to give you a clear shortcut to understanding these really vital biological processes.
That's the plan. Our mission here is to pull out the most important nuggets of knowledge, maybe hit you with some surprising facts, and spark those aha moments about how these tiniest units of life profoundly impact our overall well-being. Okay, let's get into it. Let's start with this idea of cells being incredibly dynamic, right? Always adjusting to stay healthy. It's pretty amazing how our bodies cope with changing demands at this tiny level.
Absolutely. Think of cellular adaptation as like a cell's flexible response system.
Yeah.
A lot of the time, it's a totally normal protective thing. It lets tissues handle increased workloads or different environments.
Okay.
But, and this is key, if the stress keeps going, some adaptations can actually be a sort of quiet first step towards disease. Take hypertrophy, for instance.
Hypertrophy.
That's simply an increase in cell size.
So cells just getting bigger, is that it?
Pretty much, yeah. Our sources point to the heart as a classic example. If
Yeah.
someone has chronic high blood pressure,
Right.
their heart muscle has to pump harder.
Makes sense.
Well, those individual heart muscle cells, they can't really divide to make more cells. They're what we call a permanent tissue. So instead, they get larger, bulkier to handle that increased workload.
Oh, like a bodybuilder's muscles getting bigger from lifting weights.
Exactly like that. But you also see this in perfectly normal situations, like the uterus during pregnancy. It's smooth muscle cells. They actually do both. They get bigger and they increase in number. It's a perfect physiologic adaptation to make room for the growing baby.
Okay, so hypertrophy is bigger cells, but then you mentioned hyperplasia that's making more cells. How does the body choose?
It really depends on the type of cell and the specific trigger. For hyperplasia, think about breast enlargement in a pregnant woman. Hormones signal the glandular cells to multiply, increasing their numbers. That's physiologic hyperplasia, totally normal, expected.
Right.
But then you have other situations. Say someone has poorly controlled asthma and they're exposed to irritants constantly. This can cause the cells lining their airways to multiply, specifically increasing the number of mucus-producing cells.
So the body's trying to protect itself?
It is. But in this case, the adaptation backfires a bit. That excess mucus actually ends up contributing to breathing problems. So that's more of a problematic or pathologic change.
And what about the other way around? When cells actually shrink or decrease in number, are they just giving up?
Aha. Not quite giving up, but they definitely downsize. That's atrophy. Like imagine an arm or leg that's been immobilized in a cast for weeks.
Yeah, the muscles waste away.
Exactly. The muscles aren't being used, so the cells reduce their size. The cell basically starts dismantling some of its internal machinery, like a factory shutting down unused production lines. It makes less protein, breaks down more existing protein, using this internal recycling system called the ubiquitin proteasome pathway. It's all about conserving energy when demand is low.
So cells can get bigger, multiply, or shrink.
Okay.
But then there's this other one, metaplasia, which sounds completely different, like the cell changes its whole identity.
It really does, and this one's super important to understand. Metaplasia is a reversible change, where one mature cell type gets replaced by another mature cell type. The textbook example is Barrett's esophagus.
Ah, from acid reflux.
Precisely. If you have chronic acid reflux, the normal lining of your esophagus, it's a squamous type, built for protection against friction, gets constantly bathed in stomach acid. It can't handle it.
So it changes.
It adapts. Those squamous cells transform into a type of cell more like what you find in the intestine, a columnar type, which is better equipped to resist acid.
Wow. That's quite a switch.
It is. But here's the catch. While it's an adaptation to survive the acid, this new intestinal type cell doesn't belong in the esophagus, and having it there significantly raises the risk of it progressing to dysplasia, those disorganized cells we'll talk about, and eventually a type of esophageal cancer called adenocarcinoma.
Whoa, so adapting can actually lead to cancer risk down the line. That seems like a major downside.
It's the ultimate double-edged sword, isn't it? Another big example is in the airways of long-term smokers. The normal cells there are delicate, ciliated columnar cells designed to sweep mucus and debris out.
Right.
Chronic irritation from smoke makes them change into tougher, flatter, squamous cells, more like skin cells.
For protection again.
Yes, better protection against the smoke itself, but the cost is huge. These new squamous cells don't have cilia, so they can't clear mucus effectively, leading to chronic cough and infections. And crucially, they are much, much more prone to becoming cancerous lung cancer. The cell's just trying to survive the immediate stress, but it might create a much bigger problem later.
So, okay, these adaptations are fascinating, really clever protective mechanisms in a way, but they clearly come with some serious risks, right? What's the sort of main takeaway here for us?
I think what's truly profound is seeing how the cell's fundamental drive to survive under chronic stress can paradoxically pave the way for disease. It just highlights that double-edged nature of adaptation. Our bodies are always trying to find balance, right? Homeostasis. But sometimes the struggle itself creates new vulnerabilities. These changes, especially metaplasia, are often a big warning sign.
And sometimes that struggle fails. The cells just can't adapt anymore. The stress becomes too much, leading to actual injury or even cell death. Okay, this is where it gets really interesting. What's that point of no return for a cell?
That's the absolute crucial difference. Reversible versus irreversible cell injury. Think of reversible injury like a boxer getting stunned but still on their feet.
Okay.
The cell might swell up. Cellular swelling is a key feature. Its energy factories, the mitochondria, might get puffy. You might see little blebs forming on the cell membrane. But if the stressor is removed quickly enough,
It can bounce back.
it can recover. Yeah. Maybe think of a really brief interruption of blood flow to your heart muscle. The cells might swell, show some changes, but if blood flow is restored promptly, they can often return to normal. The main issue here is usually a drop in energy, in ATP. That messes up the cell's ion pumps, especially the sodium-potassium pump.
It pumps water in.
Exactly. Water rushes in, causing the swelling. You also see things like ribosomes detaching from the endoplasmic reticulum, which means protein synthesis drops off, but again, potentially reversible.
But once you cross that line, there's no going back. The cell's down for the count.
Precisely. Irreversible cell injury means the damage is too severe. The cell's defenses are breached beyond repair. A key sign is rupture of the plasma membrane, the outer boundary. Also, the lysosomal membranes inside might break, releasing digestive enzymes.
Oh, so it starts digesting itself.
In a way, yeah. And the nucleus, the control center, undergoes dramatic changes. It might shrink down, pinosis, fragment, karyexis, or just fade away, karyolysis. At this point, the damage is permanent. The cell is destined for death.
So how do doctors, like pathologists, tell the difference when they look at tissue? How do they know if it's just disordered cells that might recover versus something truly dangerous, maybe cancerous?
That brings us to the distinction between dysplasia and neoplasia. It's a really important one. Dysplasia is essentially disordered growth. Think of it like sloppy construction work in a tissue.
Okay.
The cells aren't uniform anymore. They vary in size and shape. That's called pleomorphism. Their nuclei might look bigger compared to the cytoplasm or darker, hyperchromasia. They lose their normal orientation within the tissue, and they might be dividing more often than usual.
That's not cancer yet.
Crucially, no. Dysplasia is considered a precursor lesion, a warning sign. It's often not clonal, meaning it didn't arise from a single rogue cell, and it can sometimes be reversed if you remove the underlying stressor, like treating an HPV infection that's causing cervical dysplasia.
And neoplasia is the real deal. Full-blown, uncontrolled growth.
In essence, yes. Neoplasia means new growth, and it generally refers to tumors, which can be benign or malignant. When we talk about cancer, we usually mean malignant neoplasia. This is typically clonal arising from one abnormal cell, and it's characterized by uncontrolled, irreversible growth.
So what does that look like under the microscope?
Often much more dramatic than dysplasia. You can see extreme disorganization, cells that look truly bizarre in shape and size, very high nucleus to cytoplasm ratios, lots of cell division, sometimes abnormal-looking divisions. These cells have lost their normal function and structure, and in malignant forms, they often gain the ability to invade surrounding tissues and spread. That's the key difference.
It's just incredible how cells try to adapt, but when that fails, these really intricate pathways of cell death kick in. It's almost like the cell has a choice Make a clean exit or have a messy collapse.
That's a great way to put it. And it is a highly regulated process, mainly divided into apoptosis and necrosis. Apoptosis is often called programmed cell death.
The clean exit.
Exactly. It's like a quiet, dignified, self-destruct sequence. The cell actively orchestrates its own demise in a very controlled manner. It shrinks, its DNA gets neatly chopped up, the internal components get packaged into these little membrane-bound bubbles called apoptotic bodies.
So no spilling of contents.
Right. And these bodies are then quickly gobbled up by neighboring cells or immune cells. It's an energy-dependent process, requires ATP, and importantly, it doesn't trigger inflammation. Very neat and tidy.
Why would a cell do that? Self-destruct.
Oh, it's essential. For normal development, like getting rid of the webbing between our fingers and toes when we're embryos. Also for tissue maintenance, removing old or damaged cells. And critically, for eliminating cells that are potentially dangerous, like ones infected with viruses or cells with significant DNA damage that could become cancerous.
How does it trigger this?
There are specific molecular pathways. The cell uses a family of enzymes called caspases. Think of them as the demolition crew. They get activated by signals that can come either from inside the cell, intrinsic pathway, often triggered by things like DNA damage, lack of oxygen, or loss of growth factor signals,
Okay.
or from outside the cell, extrinsic pathway, like when an immune cell delivers a death signal by binding to specific receptors on the cell surface. A really key player in the intrinsic pathway, sensing DNA damage, is that tumor suppressor gene we mentioned, P53. It can halt the cell cycle for repair, or if the damage is too bad, trigger apoptosis.
And necrosis is the messy collapse.
Pretty much the opposite of apoptosis. Necrosis is uncontrolled, accidental cell death, usually resulting from acute injury like ischemia or toxins. It's almost always characterized by inflammation. The cell swells up, the membrane ruptures,
Filling everything out.
right, spilling its guts, essentially. This triggers an inflammatory response in the surrounding tissue. And yes, as you picked up on, there are distinct types of necrosis, each leaving a different footprint, telling a story about the injury.
Okay, let's quickly run through those again with some examples.
Sure. First, coagulative necrosis. This is the most common, seen in most solid organ infarcts, heart, kidney, spleen, resulting from ischemia. The basic tissue architecture is often preserved initially, like a ghost outline of the cells, but the nuclei are gone. And the cytoplasm looks more pink, more eosinophilic, because the proteins are denatured. Think of a classic heart attack.
Got it.
Then liquefactive necrosis. This is typical in the brain after a stroke or in bacterial infections forming an abscess. Here, enzymes, often from neutrophils, completely digest the tissue, turning it into a liquid goo.
And the cheese-like one. That
Yeah.
sounds memorable.
Yes, caseous necrosis. That's the hallmark of tuberculosis, though some fungi can cause it too. Grossly, it looks like crumbly white cheese. Microscopically, you see amorphous granular debris in the center, usually surrounded by a ring of inflammation called a granuloma.
Okay.
Then there's fat necrosis. This happens typically with acute pancreatitis, where enzymes leak out and digest fat tissue, or sometimes after trauma to fatty areas like the breast. The released fatty acids combine with calcium in a process called saponification, forming these chunky white deposits.
Interesting. What about fibrinoid necrosis?
You see that mainly in blood vessel walls, often in the context of autoimmune diseases like vasculitis or severe hypertension. Immune complexes and plasma proteins like fibrin leak into the vessel wall, creating these bright pink, smudgy deposits under the microscope.
So many ways for things to go wrong at the cellular level.
Indeed. And lastly, gangrenous necrosis, typically affecting limbs or sometimes the bowel due to compromised blood supply. Dry gangrene is essentially coagulative necrosis, where the tissue dries out and becomes mummified. Wet gangrene is when there's a superimposed bacterial infection, leading to liquefactive necrosis on top of the ischemia, making it swollen, foul-smelling, and much more dangerous. Think of a diabetic foot infection that's gotten really bad.
It sounds like other things besides just cutting off blood flow can cause this irreversible injury too.
Absolutely. A really interesting, almost paradoxical one is reperfusion injury.
Reperfusion, so that's when blood flow comes back.
Exactly. You've just managed to open up a blocked artery, say in a heart attack or stroke, restoring blood flow. But ironically, the sudden return of oxygen can actually worsen the injury in some cases.
How? That seems counterintuitive.
When oxygen rushes back into damaged cells, it can lead to a burst of free radical production, these highly reactive oxygen species. Plus, there can be calcium overload and increased inflammation, all contributing to more cell death than the initial ischemia alone might have caused.
Wow. Okay, what else?
Well, ionizing radiation, like from X-rays or radiation therapy, it directly damages DNA, causing double-strand breaks, which are very hard to repair. It also generates free radicals, particularly hydroxyl radicals, from water in the cells.
And UV light from the sun.
UV radiation, like from sunlight or tanning beds, has a different signature. Its main damage is causing adjacent thymine bases in the DNA strand to kind of stick together, forming thymidine dimers. Our cells have repair mechanisms for this, but if they're overwhelmed or faulty, these dimers can lead to mutations and commonly skin cancers like basal cell or squamous cell carcinoma.
This brings up a really important question, I think. How do we actually see these fundamental principles, adaptation, injury, death playing out in our own bodies? In real health conditions, in disease? Can we connect these cellular mechanisms to some clinical scenarios?
Excellent point. Let's try. A great example is the concept of watershed infarcts.
Watershed, like a boundary.
Exactly. These are areas and organs that sit right at the border zones between the territories supplied by two different major arteries. They get blood supply from both, but it's the furthest reach for each artery.
So they're vulnerable.
Highly vulnerable to drops in overall blood pressure or hypotension. In the brain, key watershed zones are between the areas supplied by the anterior and middle cerebral arteries, ACA, MCA, and the middle and posterior cerebral arteries, MCA, PCA. If someone has a severe hypotensive episode, like during surgery or shock, these areas can suffer ischemic damage first, leading to specific patterns of stroke, sometimes causing weakness predominantly in the shoulders and upper arms, the man-in-the-barrel syndrome.
Fascinating. Where else?
In the heart, the subendocardium, the innermost layer of the heart muscle, is furthest from the coronary artery supply, penetrating from the outside. So it's a watershed zone, susceptible to ischemia, often leading to what's called a subendocardial infarction or NSTEMI. The kidney cortex and the liver's centrolobular zone, zone 3, are also vulnerable watershed areas. Same for parts of the colon, like the splenic flexure and the rectosigmoid junction, which lie between major arterial supplies. Ischemic colitis there isn't uncommon in elderly patients with atherosclerosis after a hypotensive event.
So location really matters for blood flow vulnerability. What about fatty change or steatosis? You mentioned the liver.
Right, the liver is the classic site. You see it in non-alcoholic fatty liver disease, NAFLD, strongly linked to obesity and insulin resistance, where you get these large fat droplets inside liver cells, macrovesicular steatosis, and also in alcoholic liver disease, often along with inflammation and specific damage markers like Mallory bodies.
Anywhere else besides the liver?
Yes, sometimes the kidney. For example, in nephrotic syndrome, where the kidney leaks large amounts of protein, the kidney tubules try to reabsorb some of the fats, lipoproteins, lost in the urine. This can lead to visible fat vacuoles within the kidney tubule cells, and sometimes you can even see fat droplets or fatty casts in the urine.
Okay, that makes sense. What about a really acute dramatic injury example?
Maybe testicular torsion. Think of a teenage boy presenting with sudden, incredibly severe scrotal pain. The spermatic cord has twisted, cutting off all blood supply to the testes. That intense pain is the direct result of acute ischemic cell injury happening right then and there. It's a surgical emergency because if you don't untwist it, usually within about 6 hours, the testicular tissue suffers irreversible infarction necrosis.
A very clear cause and effect.
Definitely. Another acute one is acute tubular necrosis, ATN, in the kidneys, often seen after major surgery with blood loss or sepsis, leading to a sharp drop in kidney function. Certain parts of the kidney tubules, particularly the straight part of a proximal tubule and the thick ascending limb, are very metabolically active and sensitive to lack of oxygen. They get injured, slough off, and can block the tubules, leading to those characteristic muddy brown casts in the urine. The good news is if the underlying cause is fixed and the tubule basement membrane remains intact, the kidney often has a remarkable capacity to regenerate these cells and recover function.
You mentioned different types of necrosis earlier. How does that relate to whether an infarct looks red or pale?
Good question. It depends on the tissue and the blood supply situation. Red hemorrhagic infarcts tend to happen in tissues that are loose and spongy, like the lungs, or tissues that have a dual blood supply, like the lungs and liver, or if blood flow is blocked by a venous occlusion, or if blood flow is restored after the initial ischemic injury, reperfusion. In these cases, blood leaks out from damaged capillaries into the dead tissue, making it look red. A pulmonary embolism causing a lung infarct is a classic example.
Okay, so loose tissues or dual supply often means red.
Generally, yes. Pale anemic infarcts are more typical in solid organs that have a single end arterial blood supply, like the heart, kidney, and spleen. When that single artery gets blocked, the tissue downstream just dies from lack of oxygen, and without significant bleeding into it, it looks pale or whitish.
And what about those specialized inflammatory structures, granulomas? Where do they fit in?
Granulomas are fascinating. They're these organized collections of immune cells, particularly specialized macrophages called epithelioid histiocytes, sometimes fused into giant cells. The immune system forms them basically to wall off something it perceives as foreign or dangerous but can't easily eliminate.
Like TB.
Exactly. Tuberculosis is the classic cause of case-eating granulomas, those ones with the cheesy necrotic center. But you can also see non-caseating granulomas without the central necrosis in other conditions, famously in sarcoidosis, an inflammatory disease of unknown cause. Different types of granulomas can give clues to finding lots of eosinophils within a granuloma might point towards a parasitic infection, for instance. The key signal molecule maintaining these structures is a cytokine called interferon gamma, IFNA, which keeps the macrophages activated.
Okay, one last connection. Let's talk liver tumors. Can we tie specific cellular signals or growth factors to different types of liver issues?
We definitely can start to. It's complex, but certain signaling molecules play key roles. For instance, VEGF, vascular endothelial growth factor, is a major driver of angiogenesis, the formation of new blood vessels. Tumors need blood supply to grow, so VEGF is often crucial for things like hepatocellular carcinoma, liver cancer, metastases to the liver, but also benign lesions like hemangiomas and hepatic adenomas.
So VEGF is about blood vessels. What else?
Other factors like FGF, fibroblast growth factor, also support angiogenesis. PDGF, platelet-derived growth factor, can promote the formation of fibrous scarred tissue, which you might see in a benign lesion called focal nodular hyperplasia, FNH. HGF, hepatocyte growth factor, specifically drives liver cell proliferation, important in hepatic adenomas. And then there's TGF-MAF, transforming growth factor beta, which is a major driver of fibrosis or scarring. Chronic liver injury leads to fibrosis, which becomes cirrhosis, and cirrhosis is a major risk factor for developing hepatocellular carcinoma. So these signals are all part of the complex web controlling cell behavior, growth, and disease development in the liver. It really is quite remarkable, isn't it? When you step back and look at the whole spectrum, from these subtle adaptations cells make, changing their size or number, or even their identity through metaplasia, all the way to the intricate, finely tuned dance of cell death, whether it's the programmed precision of apoptosis or the messy breakdown of necrosis in its various forms.
Yeah, it's a lot.
And connecting it to the bigger picture, like we just did with those clinical examples, it becomes so clear just how fundamental cell health, cell behavior, really is to our overall well-being. These aren't just, abstract biological ideas. They're literally playing out inside us every moment, shaping our health, shaping disease.
That's a perfect summary. Thank you for walking us through all that. And thank you, our listeners, for joining us on this deep dive today. So what does all this mean for you? Well, when you consider how our cells are constantly adapting, repairing themselves, or even, sacrificing themselves for the greater good in response to everything around them and inside them, it kind of invites us to think, doesn't it? How do our daily choices, maybe our diet, how we manage stress, even the air we breathe, how might those things be whispering or maybe shouting to these tiny, incredibly powerful players within our own bodies? Here's a thought to leave you with. What one small habit could you perhaps adjust today that might offer your cells just a little bit more resilience?